This is going to be a lecture that is going to be a little technical. So for those non-surgeons, I'll try to make it simple. It's going to be probably a challenge for the surgeons. You can kind of take it or leave it, see what you think. We're going to talk about portal triad injuries, and there's some injuries that we like. They're fun to deal with. Your outcomes are generally good. This is not one of them. They're happily relatively uncommon. We're at a pretty big penetrating center in San Francisco, and we see these on occasion. The ones that get to us alive are usually more limited. The bad ones, we have a very short transit time system, so we get some really ugly ones. The experience with these kinds of injuries is relatively limited, and along with that, the data is relatively limited. We're not shy about doing data-free analysis, and some of which you're going to hear during this lecture. And there are a lot of other injuries. I'll show you some anatomy in a minute. The pancreas is nearby. The vena cava is like my least favorite combination. Portal vein, vena cava injuries. These are really hard you got to be having a good day to get out of those. Duodenum and of course liver injuries are all often concomitant. 30% blunt, 70% penetrating, depending on where you are. Really less than 1% of trauma admissions. Overall, 35 to 65% reported mortality in the various series, 100% mortality. I'll show you the data from a collected series for portal vein and hepatic artery injuries. Most of these deaths, of course, are exsanguination. They occur in the first 48 hours. So there are three elements. We're going to talk about common duct injuries. It's problematic if it's transected for reasons I'll go into. Hepatic artery injuries, this goes from easier to more difficult, and from lower mortality to higher mortality. Hepatic artery injuries, usually you can ligate these if you don't have a problem with the portal vein. Of course, the portal vein lies a few millimeters away, so they're often combined. Repair is best. Ligation creates a lot of other problems, which I'll talk about. But the bad actor in these portal triad injuries is the portal vein. This is a study at the time I regard as sort of the definitive study of portal triad injuries. There's not been much since then. This is 7 or 8 centers, combined series of patients that Jerry Jerkovich, Dave Hoyt, and Fred Moore co-authored. It still, I think, is a definitive study. Overall mortality, 51%. You can see portal venous and hepatic artery injuries were about the same if they were isolated. And if they're isolated, typically they're less severe. Bile ducts, low mortality, which is what you'd expect. 100% reported mortality in the series. There were only 6 or 7 patients in this group for combined portal vein and hepatic artery. So if you get the two of them, you got to be having a really good day to get out of that. Portal vein and bile, and then portal vein or hepatic artery and bile less so. So you get an idea of the spectrum. Again, portal venous injuries are the bad actors. Bile ducts isolated are not so bad. They die from associated other injuries, typically liver, and hepatic artery somewhere in between. So the operative priorities, this goes without saying, a rapid ID of hemorrhage and hematoma. Our residents are fond of doing what I call the left upper quadrant or right upper quadrant dog paddle, and the teaching folks in the audience know what I'm talking about. They kind of do this, trying to control a hemorrhage. It's not going to work. It's great for the liver. It's fine for some other things, but the porta hepatis doesn't respond to packing very well. So if you've got a suspected injury, pack what you need to, but you need to explore this fairly quickly with immediate temporary control of whatever you can. The portal hemorrhage usually is massive. Pringle and Coker maneuvers, and I'll discuss those in a little more detail. The usual operative adjuncts, you heard about some of the resuscitative adjuncts from Kim Davis a minute ago, massive transfusion protocols. Hypothermia is a big problem in these patients, and of course damage control, hepatic packing, rip the spleen out if it's injured, temporary GI closures. Because of the need in portal triad injuries to cross-clamp the porta, the so-called Pringle maneuver, and the need to do that for more than just a couple of minutes, usually you can forget about closing the abdomen, because what happens if you occlude the portal vein? Guess what the bowel does? It blows up like a balloon, even if you are using judicious amounts of crystalloid. So this is what we're talking about. A little pointer in here. This is the area for you folks at home. I'll give you a larger version in a minute. So you can see the ductal system here, the artery with the cystic artery and the bifurcation here, and behind all that, the portal vein with its multiple collaterals, making it really, again, troublesome to get to. This is the area we're talking about, and again, for those folks watching at home in their bedroom slippers, this is, again, And you see back here is the vena cava, and so often it's really hard to wing a bullet into this area without hitting lots of things, which is why the mortality is so high. Here's another anatomic diagram. I'll just point out a couple of things. Number one is the collaterals. There is a stretch of portal vein within which there are few collaterals, but there are always these pesky, unnamed little branches attached back to the pancreas. And years ago when I was in San Diego, helping Dr. Orloff do some of the portosystemic shunts, these kinds of things were commonly encountered. We don't see them that often in the surgery we do today. The other aspect of this, of course, is the portal vein as it transitions from superior mesenteric vein to the portal vein behind the pancreas. So injuries to this area are problematic. There are ways of getting control, but that's another potential pitfall. So let's go on to talk about common bile duct injuries. The problem with common bile duct in normal, healthy, average age 34-year-old gunshot wound patients, it's a normal caliber. So those of us that like operating on the common duct like operating on big fat common ducts, 11, 12 millimeters, something you can sew to, 4 to 6 millimeters. 6 is the upper limits of normal, assuming they haven't had a cholecystectomy. The vascularity of the bile ducts is relatively poor. There's almost no mobility, so unlike a rent in certain arteries where you can mobilize and stretch the thing together, you can't do that with the common duct. The dissection in this area, never mind the massive hemorrhage from the portal vein and the hepatic artery, but even if you have an isolated duct, this is real tiger country because of the surrounding structures and the anatomic diagrams I just showed you. It's prone to stricture. You put it back together, it strictures. Artery, gosh, in a study probably now 30 years ago, 25 years ago, showed that two-thirds of these patients will stricture if you put the duct back together primarily. And this is experience, of course, has been repeated with Elijah Stewart, Larry Ways, and others experience repairing iatrogenic injuries in the course of laparoscopic cholecystectomy. We have a lot to learn from looking at those studies. And really, there's not as much experience dealing with the common duct anymore. We don't do as many because of ERCP and some of the endoscopic techniques. We as surgeons don't operate on the common duct to the extent that we used to. This is from the Jerkovich-Hoyt-Moore article looking at extrahepatic bile duct injuries, and you can see there's quite a collection here in the sort of mid-portion, extrahepatic below the cystic duct. Keep that in mind because it's relevant to how we fix these. One right at them and a few up above, and then some isolated injuries up here. So that kind of gives you the spectrum. It's a spread. So all of these injuries, because of their location, it's very difficult to be formulaic about saying you always do this or you never do that. Repair options for the duct, simple lateral repair. If you have a small injury, keep in mind these are 4 to 6 millimeters. It isn't very big. It's a tiny little structure. And repair, again, its vascularity isn't that good. You're going to probably hourglass this thing. It may be fine in a damage control situation. They can sometimes be dilated. The common duct, of course, we know from experience that if you ligate it, it actually will dilate fairly readily. And certainly with stone and other tumorous and stricture obstructions, it dilates up nicely too. So probably the hourglassing isn't a big problem. Most people would not put a T-tube in a normal-sized common duct. Simple lateral repair with a T-tube, again, is another option if you have a generous common duct for whatever reason. But for people with normal 4 to 6 millimeter ducts, I wouldn't recommend this. Again, avoid primary anastomosis. More than half to two-thirds will stricture. The operation of choice really is a Roux-Y choledochojejunostomy, and that is what we perform for a lot of other reasons: distal stricture, obstructions from pancreatitis, occasionally stones, tumor as a bailout. It's a good operation, but again, we're operating on a big fat common duct, and these are teeny little common ducts. Roux-Y hepaticojejunostomy for injuries that are above the cystic duct takeoff or higher up in the porta, and that gets even trickier, dissecting all these out. It's probably not something you're going to want to do in the setting of a damage control operation. We rarely do, although choledochoduodenostomy is a commonly performed operation for strictures. It's easy, it's safe, it's one anastomosis. We see a lot of recurrent pyogenic cholangiohepatitis at San Francisco General with the Asian population. So this is an operation that allows the GI guys to get up there and do other things. So we don't tend to use this in the setting, again, because it's the duodenum. We don't like messing with the duodenum if we don't have to. So this is something we probably would use rarely. Temporary ligation. This is an interesting approach, and it has been used. There are a handful of case series. There's good evidence in animal experiments that if you actually ligate the common duct, within about 5-6 days or so, the common duct will dilate up nicely, allowing you to do a delayed anastomosis if you think you have that much time. I can't recommend this. I have no personal experience with this. It's been described, and maybe there are a couple of you in the audience, I'm guessing with a few more gray hair maybe than I even have, that have tried this, but it remains, I suppose, a remote option. Patch repair, people have tried patching it with a gallbladder. They've tried saphenous veins. The reports from Europe of saphenous veins, some authors have found they stricture down. Others have had better results with this. Round ligament patch, I'll show you in a minute. I think one of the bailout maneuvers that we've used in our hepatobiliary work occasionally for patients with a hostile porta, typically from chronic pancreatitis, and stricturing is a cholecystogenostomy. And the data, which is pretty good, it's older data, suggests that about 80+% of these anastomoses are durable over a fairly prolonged period of time. So it's one way of getting yourself out of trouble. But recognize you got to do it, you'd like to do it right the first time, and one of my former chairmen used to say you can't unscrew a patient by rescrewing him. It took me about 10 or 15 years to figure out what he was talking about, but I think I finally got it now. Liberal use of cholangiography is worth mentioning. The complication rate of missed injuries to the bile duct, depending on the mechanism, about 75-80%. So these patients really get into trouble, so it's worth, if there's any doubt at all about the presence or absence of a common duct injury or ductal injury, do a cholangiogram, take the gallbladder out and put a catheter into the cystic artery, just like we did in the good old days. Cholecystectomy is usually performed for these repairs, but not always. Stents are controversial. There's not a lot of experience in trauma. Sphincterotomy with lateral repair is also controversial. And again, if you're interested in pursuing this further, take a lesson from our laparoscopic common bile duct injury experience. Enteric anastomoses are really the gold standard and probably the best. So this is a nice Roux-Y choledocogenostomy. Looks very nice. The gallbladder's gone, but what do you have here? You have a big fat common duct that's about 3/4 the diameter of the jejunum. That's not what we're going to be dealing with in the trauma patient. So it looks nice. It's a nice anastomosis. This is an in-to-side. That's fine. One of the things that another one of these very occasional cases is repairing this common duct or doing this anastomosis using the theme of Correll. It's actually creating a Correll patch by doing your resection line there, so you're incorporating a segment of the cystic duct, still vascularized, leave the cystic artery intact, taking out the gallbladder and anastomosing the limb up to this. The stricture rate of the anastomosis is going to be purely a function of how big it is. So a little teeny tiny duct end to side is not going to be very big. Side to side is going to be bigger. This, using a Correll patch technique, is going to be bigger. And another option is doing this, which is a side-to-side choledocogenostomy. That's a bigger picture for those of you at home that can't see this. This is hand-sewn, stapled off, or either ligated. This shows a side-to-side. This is like what we would do for a choledoco duodenostomy, showing here you make your incision one direction vertically here and horizontally here and bring the things together. You can get a pretty good anastomosis that way. This is a hepconod, which is a technique that we've used at our center, again dealing with bile duct strictures. I years ago pulled a stent out of a kid that wasn't expected to survive that had caused chronic bile duct obstruction. Ducts are nicely dilated. This makes for a nice broad anastomosis. Again, it's trickier, much trickier to use in a trauma patient with normal sized ducts. So if you have a more generous duct, this is something to consider. This is just as a diagram of a patch repair using falciform and round ligaments. I have no experience with this or veins. It's mainly been described in isolated case reports and occasionally in Europe. This is the loop or Roux cholecystogenostomy. This is the bailout that I was talking about a minute ago. It's fast, it's simple. This illustration is from a different operation, so I've kind of chopped it off here, but you can see that basically it's a loop of jejunum pulled up to the gallbladder, sewn up, a simple two-layer anastomosis. The bile then comes down the common duct, does not go down through the ligated or injured common duct there, but out through the gallbladder. And again, it's probably underutilized. It seems to be durable based on our experience in non-trauma cases, in up to 80% of patients. And there are no bridges burned. You can always go back and do your porto or your choledocogegenostomy or hepatocogegenostomy at a later time. Moving on to portal triad vascular injuries. This is the Paddock artery injury, 29 patients. You can see a bunch of them are up here on the right side, and that's fairly simple. Back in the bad old days, we used to ligate the right hepatic artery fairly frequently. It was a fairly common way of approaching massive bleeding from the liver. Now we tend to pack and use other things. More embolization now than we used to, but this can be done safely. You see the rest of the spread here. So what do we do with the hepatic artery? You can ligate it, basically, as long as you have an intact vein. If you remember the physiology, about half the blood supply to the liver comes from the hepatic artery. It's richly oxygenated, but the flow is a lot less. The venous blood coming from the portal vein is less well oxygenated, but the flow is so massive, it delivers the other 50% of oxygenation. So with one or the other, you will not have hepatic necrosis. And there, in the vast literature out there, or not so vast, no late deaths attributable to hepatic necrosis with normal vein and collateral. I stress, you got to have a normal vein and collateral. That's a little less common with these injuries. A lot of patients have liver injuries and get packed. If you're going to ligate the hepatic artery and pack the liver, you're going to have trouble. Trust me. High mortality associated with graft repair. Don't try to do that. Some of these patients have pancreatic injuries. It's just asking for trouble. There's probably a selection bias here, maybe a little bit. Cholecystectomies probably should be done, again, when there is hepatic packing. So now you've packed with pressure. You've occluded essentially portal inflow from a segment of the liver, and you've ligated the hepatic artery. You will have liver necrosis. So if you pack, just be prepared for that. If it's a lateral segment or something and you have to do it, that's fine. But if you have to ligate the hepatic artery and you pack vigorously the rest of the liver, you'll probably have some degree of hepatic necrosis. If you ligate it, it may compromise a biliary anastomosis too, something to think about. It's probably worth it. And there's really no experience with stents, endovascular stents, at least in the setting of trauma. At least we have no experience. I'm not aware of a lot anywhere else. It's probably still developing. Most of these patients are in the operating room, lickety-split. This is, I hope you can see this for the viewers at home. This shows ischemia with arterial ligation. This is something that all the surgical residents should memorize. You need to know what arteries you can ligate with impunity. So the celiac, you can ligate with that with impunity because of the rich collateral through the SMA. The hepatic artery, right hepatic, all pretty low incidence of ischemia, even the common hepatic. Hepatic down here a little more so than the common hepatic because of the gastroduodenal collateral. But basically all of these vessels are associated, except when you get down here to the renal, which we know, the vessels in the celiac are associated with relatively low incidence of ischemia with simple ligation. So moving on to the most difficult, these are portal venous injuries. This is the most common cause of exsanguinating hemorrhage, common cause of early death. Exposure is difficult. It lies behind the artery, behind the portal or the common duct. Collateral veins can be extensive. There's usually a segment where there's not, but depending on where the injury is, you can get into all sorts of gastric and pancreatic collaterals. This shows the portal triad injuries. This is out of the same paper by Jerkovich, Hoyt, and Moore. You can see a whole cluster of them right sort of in the mid portion, 38, a few down here, and a number behind the pancreas and a few up in the porta hepatis. So not so common up here. Most of them occur in the mid portion of the vein. This just shows you the anatomy. Again, rich collaterals. You got your gastric collaterals, splenic vein coming in here. The pancreas overlies all of this, and we all hate venous injuries anyway. Get help if you're going to do this. This is not something. Don't try this at home by yourself, kids. Call your colleagues in, your fellows. We've had cases at our institution where we've had 4 attendings operating. That one extra set of hands sometimes makes a difference. Pringle, proximal and distal, wide coker for posterior compression. I'll show you some pictures in a minute. Retropancreatic injuries require division of the neck of the pancreas. Do not hesitate. More distal SMV exposure you can get to through the underside of the pancreas. So these are technical things. This is out of a non-trauma manual, but this thing looks, for the surgeons in the room, doesn't this look like a coker clamp? Don't use a coker clamp. I don't know who drew this. It looks like a coker clamp. This does not look like a vascular clamp. If you're going to do this, use an angled DeBakey or something gentle. It's not going to crush the hell out of the hepatic artery. We use sometimes a Ramel tourniquet, which works well also and is a little easier to stay out of the way. But this shows the Pringle, oftentimes just done with your thumb and your forefinger in your left hand by sliding your finger through the foramen of Winslow, the gastroepiploic foramen. This shows a widely cochlearized duodenum. You have to get behind these. If you've got an injury behind the pancreas or proximal to the pancreas, in the vicinity of the pancreas, you have to get behind it. Putting downward pressure doesn't work very well. These are just simple technical aspects. So for the residents, don't go down, bring something up to you, get your hand behind this. And you can see here, this shows the surgeon's finger behind the portal vein, which is now lacerated. You can get all the way back here to the superior mesenteric artery if you want. Once you have this compression, you've at least stemmed the flow and you can get on to what you need to do. And this is a quick way to identify if you're lost and can't find the vein from below. Just run along this duodenal sweep, take down some of the fat. It's going to be sitting right there. This shows division of the pancreas. There are the dorsal ventral pancreatic or arcade and the arteries in here. This shows it tied off. This is, again, a non-trauma case. You can use a staple in here. Be careful you don't injure the vein more thoroughly. But in the heat of battle, you got a bleeding vein. This amount of small arterial bleeding is probably not going to be a major concern. Happily, in the vast majority of patients, there are almost no collaterals that connect the superior mesenteric, i.e. portal vein, up through the pancreas. So there's usually a friendly plane in there where you can do just this. But an injury behind the pancreas, they don't show the big hole from the knife or gunshot wound there, mandates dividing the pancreas in order to get to the venous injury underneath. Posterior injuries, you could sometimes have to fix them just like the vena cava. This is a smaller vein, although sometimes it's pretty good size. You can open up the front wall, fix them through the back wall. There's not a lot of mobility, not something you can flip over, and it's very difficult to access the posterior wall of the vessel. So occasionally you have to do it from back to front. Lateral repair, the survivors from this injury are largely simple lateral injuries that can be compressed easily and just stitched closed, even with a little hourglassing. If you get into interposition or vein grafts, I've used the internal jugular on one occasion where we had just a money shot, isolated injury, nothing else going on. We had the luxury of time. Patient had no other injuries. That's very uncommon. So again, in the heat of battle, this is not going to be a very good option. Ligation may be the best option under the setting of severe damage control. Portosystemic shunts have been talked about, but it's probably not the time to do it in the initial operation. This just shows, this is obviously some other pancreatic injuries too, but it shows the pancreas now split in half. You've got a through and through, typically a gunshot wound, once in a while a knife wound, with a hole in the front wall and the back wall, and there's a bigger picture for you folks at home. This is the same thing we do for the vena cava on occasion where you can't get enough mobility to go back behind and fix the back hole in the back wall. So what happens? Portal vein ligation. Collateral's okay in about 80% of patients. Intra-abdominal compartment syndrome, if you do this, if you ligate at your abdomen, it's just like an SMV injury. Your belly's going to blow up like a balloon. You will not get these patients closed, at least in the first several days. Collaterals usually do develop in the first 4 to 5 days, and most of these patients, the bowel edema will subside. You'll get them closed. Late portal hypertension seems to be rare. They always need a second look. There really are very few reports of bowel necrosis associated simply with portal venous ligation. However, that collateralization depends on intact small bowel mesentery. So if you're doing a concomitant small bowel resection, all bets are off for that. Those are patients you really have to watch, and we've had a couple of cases over the last 20 years where we've gotten into trouble with this kind of thing, or with SMV injuries in the setting of small bowel resection. So beware small bowel resections. This just shows some shunts. I'm not going to spend a lot of time in that. So just to summarize, rapid idea of control of hemorrhage, Pringle, get your hand behind the pancreas, pull those structures up, compress them with your fingers, and get your clamps on. Dissection of the distal vein, split the pancreas in half. Do not hesitate if you've got an injury behind that. You'll never get to it otherwise. Primary repair for portal venous injuries, if you got a simple one, that's great. Hourglassing is not going to be an issue. Ligation, if you're in the major setting of damage control, it's probably not wise to try shunt interpositions. Very carefully selected cases like the one I described, maybe, and save the portosystemic shunts for later. Management of hepatic artery injuries, lateral repair, tiny little things, yeah, fix them. Ligation in almost other cases. Again, be careful. You can't ligate the hepatic vein and ligate the portal vein, or hepatic artery and portal vein at the same time. something's got to get blood flow to the liver. You're going to have a dead patient at the end. Interposition grafting, again, this is going to be, these are not great big arteries, only with associated portal vein injuries. We don't have a lot of experience with stents in this area, but it's kind of a short vessel. I suppose in isolated cases that would be one consideration. And again, careful assessment for hepatic ischemia. Bile duct injuries, remember cholangiography, don't miss something, even if there's a slight suspicion. Lateral repair for small injuries, the enteric, hepaticojejunostomy is still the gold standard, or choledochojejunostomy. Maximize the length of the anastomosis, how big the thing is to prevent subsequent strictures, and consider the cholecystogenostomy as a bailout for those injuries that are located below the cystic duct takeoff. So I'll stop there. Surgeons can debate a lot of this. If you get everybody in a large room like this together, there's probably just still a small number of these injuries we all have. But I thank you for your attention. Thanks.